I am Nicole, and the title of my presentation today is Knowing ME, Knowing You, which is based upon research I conducted on behalf of ACU as an honours student in 2023. It is a qualitative study exploring the lived experience of people living with severe ME, and it's currently undergoing preparation for hopeful publication in the Australian Occupational Therapy Journal. I'd like to acknowledge the contributions from my supervisors, Julie Hughes, who you'll meet soon, and Wendy Milgate, as well as Alex Beavers, who completed the quantitative component, and of course, Rachel Makepeace, our consumer advisor. So the structure for my presentation today is as follows. I will define severe ME, and then describe the study background and design, and then present the findings and discussion and conclude with implications for OT practice. So first of all, what is ME? ME is an acquired neuroimmunological disorder with widespread dysregulation of cellular energy metabolism, ion transport, and cardiovascular symptoms, with an unclear etiology. Most body systems are affected, which impact physical, cognitive, and psychological function. Post-exertional neuroimmune exhaustion, or PEN, is the characteristic symptom, a type of fatigue that cannot be alleviated with rest. The fatigue can be immediate or a delayed energy decline in response to minimal physical or cognitive effort, which also exacerbates other ME symptoms and can have a prolonged recovery time. Compared to other health conditions also associated with fatigue, such as depression or cancer or multiple sclerosis, ME clients consistently score lower on quality of life scales. I just want to signpost, this is a heavy slide, but stay with me. This is the classification system to diagnose ME. So ME is diagnosed by ruling out all other health conditions, which is often hindered by difficulties, first of all, finding a clinician who can do this. The lack of standardized diagnostic classification globally also complicates gaining a timely diagnosis, with each classification system using different terminology. The Fukuda definition uses only the term CFS and also lacks PEM as a critical criterion, while the Oxford definition includes broad symptomologies which often overlap with other conditions. The Canadian consensus criteria is more specific, incorporating PEM and neurological impairments, but requires 6 months of symptoms to diagnose, which can delay treatment. The 2021 UK NICE guidelines have just been revised and also use a hybrid term ME-CFS, but have reduced the symptom duration requirement to only 3 months. Historically, the argument for using the hybrid term ME-CFS and pooling two similar yet different conditions was potentially to enhance the publication potential of research. Although ME and CFS share the symptom of fatigue, but so do patients with fibromyalgia or heart disease. And the risk of pooling ME and CFS together is that clinicians will then recommend the same treatments. And the Australian guidelines currently recommend graded exercise training and cognitive behavioural therapy for both, which, if you ask most people with ME, makes them worse, triggers PEN, and can accelerate their functional decline. So bring in the ICC. In 2011, the International Consensus Criteria was established to distinguish ME as a separate condition from CFS and has no time requirement for diagnosis, which facilitates early intervention. The ME Group Australia advocates for using the term ME and the ICC diagnostic criteria. A consensus primer is an easy-to-use tool associated with the ICC for clinicians to follow to make a diagnosis. And a person must have PEN. They must experience 3 out of 4 neurological impairments, 3 out of 5 immunological, gastrointestinal, and genitourinary impairments, and 1 out of 4 impairments involving energy production and ion exchange. And after that heaviness, I'm just now going to present a smorgasbord of symptoms that people with ME can experience. I feel like I should have maybe had some background music for you all. Okay. Now, I'd like to define what severe ME is. So the other benefit of using the ICC is that it stratifies a person's symptoms into differing levels from mild to very severe. Mild have significantly reduced activity levels by definition. Moderate, a 50% reduction, and people with severe ME, which my study targeted, have a greater than 50% reduction in activity compared to their pre-morbid levels. It's estimated approximately 6,500 Australians have severe ME, confining them mostly to their homes and beds. It's important to note, however, that the COVID pandemic has almost doubled this estimate and raises the question as to whether people with long COVID actually have ME. The capacity for clinicians to determine the symptom severity has clinical importance because it reflects the amount of social, physical, cognitive, psychological healthcare and support that a patient needs, which is important to know when accessing funding from bodies such as the NDIS. Now I'm just going to focus on the details of my study. So the ICF is a classification system used by many health professionals, including OTs, to understand the impact illness has on health, disability, and functioning. It was used as the underpinning theory for my research to address the question by exploring the impact severe ME has on daily activity and occupational participation, and the associated environmental barriers and enabling factors. The study is needed because there are limited publications on severe ME, no studies targeted specifically participation, and none in Australia. So the purpose of the study is to expand the knowledge base for OTs to improve services. And the aim is to understand the experience of severe ME and the impact on participation, specifically for the severe group who are difficult to reach for research due to their inability to participate in long studies. So a qualitative phenomenological approach for study design was chosen to explore the lived experience of people within their socially constructed realities, which suits relatively unknown topics. Participants were recruited via social media and through the research team's own networks. Qualitative data was collected between March through to July 2023 by individual semi-structured interviews online using Microsoft Teams. I collected audiovisual and transcribed data from 10 participants with interviews lasting between 30 and 140 minutes. The data was stored and password protected using Cloud Store, which is just a software program, and each participant was assigned a pseudonym to protect privacy. To analyse the interviews, I followed the 6 phases of reflective thematic analysis by Brown and Clark. This flexible technique allowed for the construction of themes from the data. 3 researchers, myself, Julie Hughes and Rachel, all with differing expertise and experience with ME, read 5 transcripts and met weekly to construct a list of codes. When a consensus was reached, I coded the remaining transcripts independently. The codes were then grouped together into themes and sub-themes to represent all of the interviews, assisted by NVivo software, which helps organise vast quantities of transcribed data. So the key qualitative research findings included an overarching theme: my circumstances obstruct my life's path. And 4 main themes and sub-themes were then developed in sequence to describe a person's typical illness journey, where themes 1 to 2, if we think back to the ICF, related to environmental factors, and 3 to 4 were more concerned with activities and participation. And now I will briefly describe each. Theme 1, stigma and neglect, referred to the challenges in finding appropriate healthcare in Australia and is considered a major barrier. Even with a diagnosis, the response from Francis's GP was, "We can't help you with that." And Eleanor was told, "You just need to push through," which rather than being offered treatment, which is what you typically expect. Participants also experienced judgment from some in the broader community, as the illness can appear invisible. At her local shops, Cheryl explained, "I feel really guilty sitting down. People look at me like, but there's nothing wrong with you." Forced into the severe ME bubble represented the shrinking physical and social worlds, with life mainly happening at home, aided by assistive technology and home modifications to conserve energy. And to accommodate sensory sensitivities, Kai explained, "I have absolutely no windows, no noise, and no light in my bedroom." Most participants only could or preferred socialising online within the ME community, which Hamish found supportive. Friendships are hard when you're not physically present, and in online groups, I don't have to constantly explain myself. Life becomes scheduled refers to the lack of choice and control over activities, with pacing being the only way to participate in daily life. Having to pace means forced rest and switching your mind off, which Hamish explains he starts days before a scheduled appointment. And essential tasks were prioritised. Davina explains, "I can see the doctor every 6 weeks, but I can't get everything done, like no dentist or hairdresser." The final theme described the participants' journey through grief and loss prior to accepting, finding a new identity and purpose in life with severe ME. Indigo grieved the loss of work, the ability to socialise, and loss of independence. However, simultaneously, participants all felt lucky in some way. As Jasmine explained, getting the NDIS and accessible home, I'm aware of how lucky I am because there are people like me who are homeless. So what does the literature say? This study confirmed what was already known about stigma and ME, but added the idea of a role reversal, where participants felt persistently frustrated having to educate healthcare professionals about the illness, the treatments that work, and the importance of short tele-rehabilitation. It's been reported that people benefit from supportive devices. However, it was found that those recently diagnosed were considering assistive technology as they were unsure how it or OTs could help, which highlights a critical role for OTs to bridge this gap for clients, to self-manage their own illnesses and slow disease progression. Bork Vidberg reported that people had fewer social connections with severe ME, and participants in this study reasoned they became intentionally more selective with who they spent their time and limited energy with. Chelsea Bartlett, who you may meet in the next presentation, through her amazing research, demonstrated that the range of occupations with ME narrows over time. And as central to OT principles, we know doing things enhances well-being. And what we now know is that people with severe ME, their activities are mostly sedentary and passive, reduce in frequency and duration, and are performed mostly in bed. It was further noted that leading a productive life was most important, and people found ways to contribute to society, such as becoming a website content developer or contributing to disability policy reform. The surprising finding that people felt lucky could represent a coping strategy, or that compared to others, they are doing quite well. And it therefore might explain why in Ballina's results, less than 80% of people diagnosed with ME actually seek support. Now I'd like to turn the attention to some implications for OT practice with a brief introduction of OT. Occupational therapists as a discipline take a holistic view of a person living with an illness or a health condition in an environment in which they live, they work, they socialize and grow, and the occupations that they need or want to do. Occupations, just to explain, include any tasks or activities that occupies a person's time. It could be eating or sleeping or caring for your dog. The goal of OT is to determine which aspects of the person, the environment, or their activities that can be modified or adapted to enable people to participate and engage in a life of their choosing. Just quickly, as I've already explained, that people living with ME report significantly lower quality of life. And one reason is that the range of activities people can do narrows. In other words, the nature of participation in activities changes because the person's world shrinks as they are forced to live within the severe ME bubble. So people with severe ME participate in tasks mostly in their home. Participation shifts from active towards passive activities with less cognitive load, such as watching TV rather than engaging in a lively debate. The frequency of tasks reduce. For example, people may shift from having a daily shower to a weekly shower. The duration of activity lowers, where, for example, reading might only be possible for 10 minutes at a time. The purpose of changing the nature of one's participation is to conserve energy with frequent rest breaks to avoid pain. And occupational therapists are able to modify or adapt activities to make them more achievable by using less energy. Other areas where OTs can aid people with ME is to address their environments, which includes social interactions. They can educate to reduce the stigma associated with this invisible illness. Collaborating with GPs, a person's employer can clarify how ME affects their daily life and highlights helpful strategies. Flexible working arrangements are crucial for people to maintain employment and their self-identity. Additionally, OTs can provide resources to family and friends who might misinterpret the person having ME as just being lazy. For those receiving formal support, educating caregivers about ME symptoms like sensory sensitivities is essential in fostering a supportive environment for the person. OTs can also contribute in other various environmental domains, including social policy and healthcare systems that can affect individuals. Living with ME makes full-time employment or study rather difficult, leading to financial strain. OTs understand funding options like superannuation and disability insurance and pensions that can help mitigate income loss. They can conduct functional capacity assessments to support NDIS applications, which Claire will explain in the following presentation. OTs can also prescribe assistive technology tailored to the individual's needs, such as noise cancelling headphones for sensory sensitivities or air purifiers to reduce odours. In conclusion, this study proposes that occupational participation restrictions experienced by those with severe ME are due to the absence of clear healthcare pathways in Australia. Unlike other illnesses, such as cancer or MS, where a diagnosis results in treatment options and support, unfortunately, people with severe ME often face stigma and neglect. Thank you, and I know that there's no time for questions now. I'll stop sharing my screen.